All right. So we're going to do a little kind of chronological thing, and our first point of time was going to be, what do we do with the mare a month before foaling? So Anna, what's your standard 1 month before foaling mare care situation?
So looking at the sort of general routine care, we, in an ideal world, the mare would have a booster vaccines, flu and tetanus, to sort of optimize maternal transfer of antibodies. In reality, that doesn't necessarily happen, and we don't sort of enforce it for our studs at all. There'll still be some transfer, and we do give supplemental tetanus, as we'll talk about later, and antitoxin, that is. We encourage strongly rotavirus vaccines for mares going to stud. So that's at 8, 9, and 10 months of gestation. Particularly important on studs where there are a high number of foals, and also where there's a previous history of diarrhea. And then EHV vaccines we also strongly encourage, and actually our studs require for mares falling down. Although it won't stop cases of abortion, it can reduce shedding and the likelihood of an abortion storm. So other just very basic things that we think about are, if as the vet that's going to be on call for that mare falling, it's really nice if we do have history of any big major sort of problems that a mare's had. So either previous falling problems, or she had a fractured pelvis and we're now trying to get a foal out there, that kind of thing. Often we don't get that kind of history, but it's nice if we do. And then things like just looking at the whole picture. So if that mare is running milk and likely to lose a lot of the good quality colostrum, it's really nice to have a plan in place for some banked colostrum. And in sort of the bigger studs, that's often in place already, and we don't have to worry about it. But it's certainly worth discussing with, if you're falling down single mares at home, it's really nice to have that chat first, because the likelihood is if they don't have a colostrum plan, then it's going to need plasma. And then obviously everything the Caslick.
Can I just ask, do you have a sort of cutoff if mares are moving to a certain place to foal? Do you have a time cutoff?
Yeah, so ideally we don't have a cutoff. It does happen that mares arrive one day and then foal that night. But ideally we recommend that they go to stud 2 to 4 weeks before the due date. But we kind of very much take that with a pinch of salt, as in if that mare's bagging up well before the due date, then get her there, because we do want them to settle in. We do want them to be exposed to those pathogens on that stud. So and we don't want to be transporting mares that are basically falling in the lorry. So but yeah, it's definitely a bit of a I had a phone call from an owner actually just last night, just basically wanting reassurance she's not going to fall in the next 2 days. But I was like, I can't tell you that. And she was well before she was due her due date, but we definitely encouraged her to get straight in there.
Right. So yeah, carry on.
So then we've moved on to the standard post-foaling protocol that we generally, I suppose not really a protocol, but what we sort of aim for with each foal. And it may vary sort of subtleties may vary between clinicians and things, but the general sort of things that we encourage mares that falling down under our watch are that we have, so as soon as the foal is born, it's really helpful to have a Brix refractometer to hand, and that's often if it's a stud, the stud will do that and look at the quality of the colostrum, and anything less than sort of 22 or 20% on the Brix refractometer indicates that colostrum is not great, and that supplemental colostrum would be really good. And we even do that so once the foal's out and is sort of sternal and looking quite happy, and the stud will get that while the mare's still down, and before there's any chance that she's that the foal's nursed or anything. So then
I guess it's worth saying there's quite good correlation between those refractometer results at that stage and then the colostrum, and therefore the foal's IgG. It's a reasonable assessment of what's likely to happen.
Yeah, absolutely, yeah. And that to the extent that sort of some studs will actually ring if there's a foal that's been born the mare had poor quality colostrum on the bricks, they may even ring to say, oh, can you come and tube this foal even before the next morning type thing, just because if they've got a colostrum bank, it's really good to get it in there. And while we're on that note, obviously it's not it sort of feels a bit sort of just jumping in with details here, but we definitely encourage the studs not to use or owners not to use a bottle to feed the foals if they do need supplemental colostrum, and we really encourage that they do have us tube that first bit of colostrum if needed, just because of the risk of aspiration pneumonia. And people do it and get away with it, but sometimes they don't get away with it, and
I think this is something I feel even more strongly about. We would see probably a foal every year that has aspiration pneumonia from being bottle fed. And okay, maybe I don't know what percentage of bottle fed foals that is. It's probably not that high, but it's so sad. And those foals die. They always die. So I would say just never bottle feed a foal. You can stomach tube them with colostrum, obviously generally done by the vets, and you can teach a foal to drink out of a bowl if it needs to be fed. Just don't bottle feed them, I'm afraid, would be my take. But anyway, I think Anna and I feel very strongly about this, and probably could rant on about it for ages. But...
And the number of foaling kits that you see, that you see for sale, they include a bottle as well. It's just that, it's quite,
it's interesting.
So then the other thing that may be done routinely before we as the vets even get there is our enemas. So a fleet enema. And some studs do it routinely. I think if monitoring, I don't think it's particularly necessary in every case, and particularly if there's good monitoring of that foal. So ideally the foal will stand, nurse, and then once it's had a bit of a suck, we'll then focus on trying to pass the meconium. So I think if they are going to do routine enemas, it's really important that they wait till they have nursed and then give the enema, because I think if you give it once it's up but it's trying to nurse and then you give it an enema, it's just more concentrating on trying to pass that meconium. Some people even give it before the foal, like literally as it comes out, and then before it's sort of attempting to stand. So I guess it has a different problem there, but it can definitely be, especially where it's not doable to have the person watching a healthy normal foal that's doing the right thing, that's not going to be watched for the constantly. It is useful to know that you give it the enema and you can actually see that it's passed a decent amount, but it doesn't necessarily mean it's not going to get an meconium impaction. Just there'll be plenty more to pass after that. And then umbilical treatment. So we encourage the owner or whoever's present at a normal birth to treat that umbilicus. So we provide actually this it's 0.5% chlorhexidine, which is generally accepted to be the best thing to be treating umbilicus.
And I didn't know that you can get it in this handy little bottle. We always make it up obsessively ourselves, and so I'm gonna get some.
Well, it's quite a small bottle, but it is it's enough for more than enough for a foal. So it's definitely less faff.
And I guess I would say again, I'm probably a bit obsessed with this, but basically don't use other stuff. No iodine, no purple spray, no anything else weirder than that. Iodine and purple spray are really drying, and the risk is that the umbilicus dries and then snaps off. And again, I mean, I was going to say I don't have any evidence, but Anna, you'd know the literature better than me. Is there good evidence?
So there's definitely that old study from, I think I had to put it later, but there is an old that looked at different.
We were going to talk more about umbilicuses later, weren't we?
We were.
We'll carry on. We'll come back.
But no, definitely worth the pink stuff. So then then we generally would, in a normal situation, if the foal and the mare's done the right thing, so the 1, 2, 3 rule of the foal standing within an hour, nursing within 2 hours, and then the mare passes the placenta within 3 hours, then we would that would all sort of hopefully have happened, and then the next morning we would do the new foal check, which I wasn't. We can't go into more depth with it, but I think wasn't going to particularly, but just a really thorough physical exam basically, and history of exactly what happened at the foaling and with the placenta. We try and encourage studs, even quite experienced studs, to keep hold of the placenta so that we can look at it, because it's quite interesting the odd little things that you pick up, which might have just been glossed over if the whole placenta's there, and but sometimes they are discarded. But it's nice to be able to look at them ourselves. And then tetanus antitoxin. So I think there's quite a lot of discussion about, well, I guess tetanus antitoxin for lots of different reasons, not just foals at the moment, and we will go into it a bit more. We do at the moment, along with I think the other major or sort of big sub-practices in the country, we do give tetanus antitoxin, and whether that will change as more evidence emerges, which hopefully will soon. Then
we're only laughing about this because we had a big discussion about it last week and concluded no one knows the answer really. And so for now, we're going to carry on probably, but it is an interesting topic, and I wonder if it will change over time. Hopefully someone will fund some nice big research study looking at antibody levels, and then we'll all be able to do good informed decision making.
Yes, that's good. And then IgG, we aim to test within generally 18 to 24 hours. Often it's the following morning, so it is closer to 36 hours. And
are you doing a snap test or are you using the lab?
So we're generally using the lab, so for a quantitative result, just because, especially for the we can go into it more, but the kind of borderline, the sort of 7 point somethings, it's quite useful to have the actual an actual value, I find, and it's really great that our lab now does have quantitative, so we're lucky with that. But before, actually, we were sending, because we have quite a lot of confidence in the Brix refractometer reading, and therefore the likelihood of foal being okay or not plasma or IgG wise, we actually were sending them externally rather than doing a snap test, just because we felt that the delay didn't sort of put too much risk on the situation. But at least I was doing that. I think there was a bit of variation between vets, but we do at weekends. We do use the snap test quite happily, and then just checking the mare. So that's very, very much part of the post-foaling check. Just a quick physical, a sort of a focused physical exam, and looking at the back end and the milk and her milk supply. Generally, tears, perineal tears and things will be something that even if they're quite severe, it'll be something that we let settle. So it's more of a just clocking and potentially making a plan for a more detailed examination of any tears going in a few days' time once the swelling's gone down a bit.
And do you routinely give them Finidine or anything, or is that just a case by case thing?
Yeah, not routinely. Not unless if she's really, really bashed up or sort of bruised and torn behind, then potentially, or if there's any question that she's stayed on, that she's not comfortable, then we would. But yeah, not routinely. Interestingly, in cows, there's some not strong. So there's some discussion about whether non-steroidals actually slow down the passage of the placenta and increase the risk of retaining membranes, but there's nothing in mares as far as I'm concerned.
No, it's definitely something I've heard, because I guess it makes sense from the point of view of the prostaglandins.
Yeah.
Interesting. I realized I should have said earlier on, if anyone has questions, we are rattling through probably quite a lot of material here, hopefully because it's useful. But if you've got questions or there's specific things you want us to talk about more, then please just put them in the chat as we go along.
So this is just a little bit about and it's a bit of a ugly wordy slide, but just sort of a bit of a sort of open the chat about tetanus antitoxin, because basically I think a lot of the evidence for giving antitoxin has been out there for quite a long time. This is from the 80s, the study, and basically just looked at antibody levels or titers in foals that were born to unvaccinated mares, so had low or minimal titers at birth, and the antitoxin did increase the circulating levels and sort of just until I think for 3 months. So that was sort of justification for the need for giving the antitoxin. But we now, with the majority of our mares being vaccinated, whether they're boosted in the last 4 to 6 weeks of pregnancy or not, we don't know, is it necessary to be giving this antitoxin? And also the questions of whether it's effective. This is actually I think this is the only preparation we can get at the moment, and it's actually only lasting for 10 hours. I thought it was 12 hours, but I checked it, and it's 10 hours, which however many foals you see, I feel like you're not going to get through a bottle of antitoxin in 10 hours. And yeah, so are the benefits outweighing the risk, which I think the bottom line is they're pretty small in this country. In other countries, the States particularly, it's not a routinely done thing because there is concern over bloodborne disease, Tyler's disease, and acute hepatitis, isn't it?
Yeah, associated with the tetanus antitoxin.
Yeah.
So yeah, they would be much more reluctant to give it, whereas here we perceive that it causes no problem, so why wouldn't you just do it?
Yeah.
I guess it's interesting, I think in a way, yeah, the other thing is that most of the mares will have been vaccinated repeatedly for tetanus, you know, loads of times. So I guess we don't really have much idea about their levels of antibody, but they're probably pretty high.
Yeah, so I just thought it was interesting to see that these were the AAP recommendations from the States, where they actually, so for these foals born to unvaccinated mares, they're recommending that that the first dose they have of the tetanus toxoid, so the vaccine, that those foals have it at 3 months of age. But interesting, because other studies suggest that the maternal antibodies, so if you did that in a had some sort of some form of immunity, then you would be that there would be no effect. It wouldn't be effective because of the maternally derived antibodies. And even in mares vaccinated, they're suggesting starting at 4 months, which definitely.
I guess they then, because then I suppose they only give a second dose and they don't give a third close together dose. Because I guess what they do sometimes talk about vaccinating foals for flu, if there's a really high risk that you vaccinate them early, but then you have to basically sort of start again at 6 months old because you can't be sure that the maternal antibodies haven't got in the way. So it's interesting, that's their protocol. And do they get away with it? They don't have a higher tetanus caseload than us?
Not that I'm aware of. That was just the so my kind of summary of it was the foals will, in the vast majority of mares that have had some vaccine, some immunity to via vaccine, these foals will receive some passive immunization, and we're pretty confident that mares that have been boosted 4 to 6 weeks out from foaling, those foals will be protected. But what about the ones that haven't been boosted close up to foaling? So maybe antitoxin is warranted in some foals, but not others. And what about the breaching of the bottle and how we should be managing how we should be storing that the antitoxin basically. I know some people freeze aliquots of the antitoxin, which goes against the data sheet of that preparation, but again, I don't think we know what it does. Let's move on from the whole.
I think it's a really interesting topic, and hopefully it will get answered in the next few years. So we're going to talk a bit more about what happens in the first week of the foal's life. I apologize if this is really teaching you stuff everyone learned at vet school, but I thought it was just useful to recap. Foals are at high risk of sepsis compared to other mammalian species. They have this open gut to absorb all this colostrum we've been talking about, but obviously it can let in loads of bacteria at the same time. They have their umbilicus and they are quite prone to respiratory tract infection as well. So they're badly designed. They're born, because of the placental design of a horse, they're born completely immunologically naive, and they rely on the passive transfer immunity. And then we have this opportunistic infection by just organisms that are present in the environment normally. So they're basically born in a very high risk state, which we have to do our best to help out. I really like this paper at the top here. It's not that new now, but it's quite a neat study. They only looked at 7 foals, but they blood sampled them really regularly for the first 3 days of life, and 4 out of 7 of those foals, so more than half, were bacteremic transiently during the first 12 hours of their life. So that's quite interesting. These foals have bacteria swooshing around in their blood that they've absorbed, and that's happening even in normal healthy foals, so let alone if you've got some kind of problem going on. And I think when handling neonatal foals, I think we'll probably talk more about this later, I'm slightly obsessed with biosecurity, but there's a reason, if normal healthy foals are absorbing a reasonable quantity of bacteria, then we do have to be careful. And I can't even, I I can't remember what this last little bit down here was going to say. I'm going to analyze faces, aren't I? Oh yeah, it was just talking about IgG. And I mean, I think I just chose these two papers, but there's plenty of papers out there showing the association between IgG and non-survival. Well, we do this on the other. Yeah, there's loads, and we could always talk more if we have time about IgG cutoffs and things, but I think certainly some form of assessment and interpretation is required.
Yeah, and it's those borderline ones, isn't it, that as we mentioned, this sort of nearly, obviously we'd rather they're over 8, but if they're nearly there, I think those what your thoughts are on those borderline ones. I've
definitely also worked with people who on really good experienced clean stud farms would let them go lower than that before they really worried about them. Do you have are you doing that kind of social stereotyping? Does it depend on the environment?
Well, yeah, I think that's very true, but I think according to that, I think we're definitely in both 8s. I think I don't think we have that many that that are very I think a lot of them are high risk basically of our stud farms. So, but I think if we have small single mare or a couple of mare owners that are in that kind of situation, I think that's where it is really it's very clean and there aren't loads of foals, and definitely would let it be happier for it to get a little bit lower.
Brilliant. We've talked a little bit about treatment of the umbilicus already. I think we've actually probably really talked about what the best things to use are, and you were talking about this reference.
That was this old so 95, wasn't it? And it just it's interesting, just they use various concentrations of iodine, and I mean the chlorhex 0.5% still back then was the big winner. So I think not much has changed.
It's kind of depressing that the paper is so old. I didn't realize it was so old, and yet people are still dipping umbilicuses in iodine.
That's true.
And blue spray. We would get every year. We get quite a lot of foals that would come in with iodine on their abdomen, and 1 or 2 with blue spray. So that's kind of depressing. And partly due to my obsession with umbilical care, I just thought I would put this case in briefly to highlight why we care about this. This foal we saw earlier this year, he was a 10-day-old polo pony foal. He'd had a very happy, good start to life, apart from he had had his umbilicus dipped with iodine, and it had dried up and snapped off a few days later. He'd had his meconium impaction treated routinely, and he was admitted here at 10 days old because he was increasingly recumbent with mild signs of colic and a fever. He was still in great shape, apart from that he had this pretty thick umbilical remnant and some horrible smelling dry blood and probably pus on his ventral abdomen. His bloods were increased, his inflammatory markers were increased, and his abdominal ultrasound showed evidence of a really quite big umbilical abscess. As I guess would always be my preference in these cases, we tried just routine antimicrobial treatment to start with. And he was doing pretty well for 3 days, and we were thinking, oh, maybe we're going to get away with this.
What was that you?
Good question. I think he had cefazolin and amikacin. I used to be very wedded to my ampicillin and amikacin, but we can't get ampicillin at the moment, so I'm having to branch out. And my current go-to in that situation, that is probably what I would choose. Yes, I think that is what we started on. We were thinking this is all going swimmingly great. 3 days later, he went non-weight bearing lame on his right hind. For us in the hospital, a foal that goes lame has a septic joint or a septic orthopedic condition until proven otherwise. And indeed, a close examination showed some mild distension of his stifle. So we, along with various other things at the time, actually tapped all 3 compartments of his stifle, and the medial femorotibial joint was definitely septic. So I guess at this point, this foal really has gone rather to pot and is now costing the owner a huge amount of money. And I mean, I suppose we can't entirely blame the iodine dipping of the umbilicus, but it definitely is all stemming from its umbilicus and certainly wasn't managed in the optimal way. So you kind of think maybe this could all have been saved. As is our preference, if we have the option, we did a full body CT scan, which actually for us is not very much more than in terms of cost, of radiograph safari, and it just means you can look for other septic joints at the same time. which really is helpful in terms of prognosis. And maybe we might have time to talk about this more later, but for these foals, having multiple septic structures, the prognosis decreases for every extra septic structure you find. So just having a good baseline of what's really going on in this foal is really helpful. So he had his stifle tapped, we did the CT scan, and then he had surgical resection of the umbilicus under stifle lavaged. And this picture on the right, I don't know actually if you guys can see my pointer. Maybe someone can tell me in the chat if you can't. But this here in the middle, this big balloon-like thing is the big, horrible, nasty umbilical abscess. These are the umbilical artery remnants. This one you can see is hugely thickened. And this actually, we had to create, well, I say we, Henry, resected the cranial pole of the bladder because the abscess was adhered to the bladder. So it was a pretty big, this foal had to have its stifle flushed and the umbilicus resected. That's quite major surgery. We don't do surgery on foals' abdomens unless we really have to. But he has been lucky. He's done well. He made a really great recovery. This is him just before discharge. He went home 10 days later, and that was a couple of weeks ago, and he's had no reported complications. So he's had a good outcome, but he's gone through an awful lot just because of an umbilical infection. So I think our obsession with umbilical care is probably justified. So probably this actually brings us very neatly onto the next topic of these foals are so at risk of infection. The obvious and somewhat old-fashioned viewpoint would be, well, why don't you just give them antibiotics when they're born? It certainly historically was the routine. Anna, what do you do these days? And do you have any, like, what would be your exceptions to whatever your rule is?
Yeah, so we don't give antibiotics routinely, and it's been quite a slow sort of gradual process for some studs to move away from that because it was so accepted and by some studs that so that's definitely been a challenge, but we don't. And I'd say really we in higher risk, and I think we'll go on to that, we've got a bit of some papers to chat about too, but if we have higher risk situations, we try and monitor with blood work and then base our antibiotics or the need for antibiotics on that, even if we do think it's, so say it's a, I don't know, placentitis mare or something, we would routinely bleed those foals, but we wouldn't necessarily routinely put them on antibiotics. So
that's interesting. So even for the high risk foals, unless you perceive a problem, you're not putting them on antibiotics.
Yeah, if they're clinically normal, and I would say
that's cool.
Yeah.
So we did just put in this paper. It's quite old now, actually, but well, it's not as old as the umbilicus paper, but it's from 2009. It was a really nice study, I think. They took more than 1,000 foals in 1 year in Newmarket, and they looked at the risk of, the incidence of infection over their first month of life. They found the overall incidence of infection was about 8%. Most of those were diarrhea, and lots of those were rotavirus, which obviously wouldn't be impacted by the use of antimicrobials. And then the remaining nearly 3% were lameness, umbilicuses, and respiratory disease. But the really important part of this paper is they found no difference in the incidence of infectious disease, whether they gave antimicrobial treatments in the first 3 days or not. And I mean, this study was massive and really well done. It was a very definitive conclusion. And
I suppose an exception when I was thinking about those situations, I mean, if a foal's born bathed in meconium, then we're not going to put it on antibiotics as a minimum. But I'd say there's a lot more to it than just routinely putting them on, because we would take that pretty seriously and run bloods, and we probably would end up we could be going down a rabbit hole with a meconium stained foal. I think you could.
Yeah, it is. I think it's really interesting, actually, though, to know that you don't, if they're born high risk but without obvious problems, to know that you're not using them. Because certainly I think I was probably taught, don't give them routinely, but it's okay if they're high risk. So it's interesting. I think that's cool. Good. Anna, what are your other top tips?
Top tips. So yes, the 1, 2, 3 rule, because with foals things change so quickly and they can deteriorate so quickly. The sort of any deviation from the normal behavior, so the standing within an hour, nursing within 2 hours, it is pretty reliable that foal's going to need some extra help if it doesn't do that. So having studs, or especially owners that aren't experienced, having them educated to pick up those those changes, because if they're used to, you know, I don't know, cows or something, that's such a different situation, and they can easily just without knowing, just completely miss the boat basically. So yeah, and then just close monitoring in general, I think can't be, you know, is so important in the early times, because yeah, you can get so behind the ball very quickly. And then hygiene, back to the hygiene. I agree. Yeah, I mean, it can't be overstated, the importance, really, can it? But
no, and I think it really sort of depends on who you're dealing with and their sort of starting point. But again, I think if people are used to dealing with lambs or calves or anything like that, their starting point is so far from what we think is a good idea that you do have to ham it up a bit, I think. And actually, I would say also for us vets, I think one, we need to be setting a good example, and also just doing the stuff ourselves, you know, not putting your stomach tube down on the floor in no packet before you put it into the foal. For me, that, I don't know, that's like the classic example where actually you've just put bugs on your stomach tube and you're going to poke them into the foal's open gut. That kind of stuff. And I think you can help owners quite a lot with that, and particularly if they're foaling multiple foals, stable hygiene and stuff becomes really important. And actually, I think in the States they've had some really good examples, I suppose, of diarrhea outbreaks where actually they end up foaling the foals out in the paddock, because the risk of they've shown quite well that there's a lower risk than if they fold them in the stables, and clearly that's a hygiene issue with the stables. So I think yeah, there's so much, I don't know, the starting point of like people washing their hands feels so patronizing, but that's definitely probably the starting point, particularly if people deal with any other kind of livestock. I don't know if you've got better examples, Anna.
No, I think definitely, and holding a horrible mucky tail of a foal, and then without glove, and then moving on to the other, like turning them around and then moving on to holding the front end and basically feeding the food to the foal, I think. Yeah. But yeah, and I think it's really difficult, especially if you've got lots of foals in one place. The stable hygiene is really difficult, because turning around stables quickly for the next mare foal is a challenge, but it's worth it. And I think when some have had a bad experience of an outbreak of diarrhea or whatever it may be, it definitely helps. It helps change mentalities and improve things, but it's just a lot can be done without those bad experiences. Oh yeah, and this is actually my colleague Tessa, we were testing today actually, and she's had this other top tip of not placing too much significance on a normal temperature in a foal, which I think is so true, because basically, yeah, foals with normal temperatures can definitely still be septic and very sick, and probably even more so than febrile ones. So kind of sepsis is always so high on the list, no matter what's there.
Okay. Oh, this is still me banging on about this wolf ender paper, and we probably can move on for this. I think we probably talked about all these risk factors, I think, already. So yeah, we can just roll on, I think.
Yeah, I think these are the three that I added to that, in terms of, yeah, and a red bag would be on that same list of if a foal's be similar to placentitis, I suppose. If a foal's born with a red bag but is clinically normal, doing all the right things, I would be quick to screen, do a blood that first day, but wouldn't necessarily put on antibiotics unless.
And you're saying you would do bloods on the first day, but then what? How often do you follow up?
Yeah, so, and it might not be quick, yeah. But I mean, basically, then if there are any problems, then I probably would follow up then. But if it continues to be clinically normal and the blood's initially normal, then I probably wouldn't necessarily run another one, which is probably, especially in the case of red bag where it hasn't been festering away necessarily. Yeah, that's probably a good point, that when they're clinically normal going forward, then you can kind of get more relaxed. Especially, I feel like once you get past the 48-hour time and things are okay, sort of, yeah. But yeah, I think that'd be different with a meconium stain foal, which I've also got here on this side.
So this was my question to Anna. Do you believe in the squeeze? And if you do, how often are you using it? Do you use it in particular patients? Hopefully everyone knows what we're talking about, but we will in a minute clarify a bit more about the details of the squeeze.
Yeah, and I think I'm sort of, I think it's really, I definitely do use it. And I think the main thing is with case selection is really important, because I've definitely also used it as a last resort, which is definitely not the way to use it. But in these mildly slow or dummy foals that they just are a bit slow to sort of get the hang of nursing, or a bit sort of wandery and dull. I've definitely had some success with it, but I'm slightly on the fence about it. I don't use it in every one, and I definitely have tried where it hasn't, I don't think, made any difference, and then it's kind of so I'm on the fence, I'd say.
And do you use it for restraint?
Yeah, so I do use it for restraint, and so I think it's quite useful for giving plasma. I often do plasma standing if you have if you have really competent handlers, which some of us does, they're really very capable, and actually I find it very sort of efficient and non-stressful for the foal and the people, just to do it standing. But certainly if I'm going to lie the foal down, then I think that it can be really, really useful for that, and you don't have to sedate. I think my colleagues, I think there's lots of variations. I think some of my colleagues do lie down every foal and would sedate them, or some may squeeze. But yeah, I think that's probably what I'm more convinced about than using it for restraint. But no, I mean, there are plenty of very good, happy success stories with it. I think you have a good one.
Well, I mean, I think my take would be pretty similar to yours, in that I would squeeze a lot of patients because I perceive there's no real downside, and I think it is useful for restraint. I would just put this case in because I have had a very small number, and they are a really small number, of cases where I've really thought the squeeze has actually made the difference. This is probably the only foal where I'm really sure it made such an amazing difference. This foal was a cesarean, which obviously sort of sets it up to be a good candidate to be squeezed. It was born with no massive problems, other than it was very much a dummy or neonatal maladjustment syndrome. It was physically very well, but it was licking the walls and completely unable to suckle from its mother. We squeezed it, and it hopped up and suckled from the mare about 10 minutes later. I mean, it's the most remarkable one I've had, and by no means are they all like this at all. But I guess that foal made me convinced that in some foals it is going to make a difference. Why? We'll rattle on through this a little bit quickly. There's quite a lot of reasons why a foal might have neonatal maladjustment syndrome or be a dummy. It's probably not one disease process. And I've listed them here. And certainly if they've had a dystocia, maybe they are genuinely hypoxic, but that probably is less of an issue in horses than it is in some other mammalian species. To be honest, they don't use their brains as much as other mammalian species. But then, they can be actually ill, which then has an impact. But it's this persistence of the fetal HPA, the hypothalamic pituitary axis, which is thought to be what makes them appear like dummies and make them sleepy and unable to recognize their mums. So if we just, or we might come back to this dystocia stuff in a second, actually, I think, because it, but for a fetus to hang out inside the mare, they've got those quite pointy little hooves, and I think we've probably all seen mares where the dystocia has gone horribly wrong, and those little hooves have caused a huge amount of damage inside the mare. So the foal needs to lie pretty still while it's inside, and it's kept asleep inside the mare with these neuroinhibitory hormones. But what you need is, as the foal is born, for those neuroinhibitory hormones to be switched off and the foal to wake up and get going. And that's what happens in a normal foal. Those hormones are switched off, the activatory hormones are switched on, and the foal gets up half an hour later, an hour later, it's cantering around. A group in the States have done more work. They've shown that if you infuse those neuroinhibitory hormones into foals, you make them look like dummies. The work is quite convincing. And it's that same group that produced the squeeze protocol. These pictures show you briefly how to do it, but if anyone wants to learn how to do it, if you just Google John Madigan foal squeeze, there's endless videos on YouTube and things. So if you talk about not doing it, the reasons not to do it would be definitely palpate these foals' chests really carefully. And if they've had a dystocia, be super confident they haven't got broken ribs. I have to say, in the hospital, we would scan their ribs. At the same, we scan their ribs and then scan their lungs, just shuffle along before we would consider squeezing them. If they've got sepsis, we wouldn't normally squeeze them at that point. If they're super premature, or if they're more than 4 or 5 days old, it's probably not going to work.
Do you repeat it as well?
Yes.
Yeah.
In general, I guess for us it's kind of easy. They're here. We spend a lot of time with them. From my point of view, I just take a sort of why would you not attitude. And so often we'll sort of let them get set up and let them get going and squeeze them the next day. But then I would repeat it for the day or two after that. It's really easy. And yeah, look up John Madigan if you want to learn how. But I think it's probably worth us just skipping back. I rather skipped over this dystocia stuff. Which maybe doesn't directly actually relate to being a dummy particularly, but I think, Anna, you're the very best person certainly to talk about how we should be managing dystocias.
Oh yeah, and it's such a, there are so many of these topics that we could talk about for more than an hour. But yeah, the decision, I mean, I think the timing, the sort of the importance of once the second stage labour starts and the waters break, the importance of timing it just can't be overemphasized. And yeah, so various studies have looked into that, including this one that found that for every 10-minute increase in stage 2 labour beyond 30 minutes, there's a 10% increased chance of a dead foal at delivery and 16% increased risk of not being discharged from hospital. This one found, yeah, it was talked about slightly longer, so 40 minutes, more than 40 minutes increased mortality. But that's the big take home. And I think the more obviously there are some geographic limitations with that, but the more we can educate owners, the big is.
And I guess, do you have any stud farms that would say the foal is stuck and bringing it in? Or would you always go out to them?
Yeah, so no, we do have one in particular that's, because it's probably about 50 minutes for us to get to from the stud branch of B&W. So they would and they have come straight in. Most of the others, because we're pretty close to the studs and a lot closer than it would be for them to get in, we do go there. But yeah, I think, and yeah, I mean, that's a big advantage if they're really close to the hospital, then yeah, absolutely, it makes total sense. They're in the right place, and if they can get it vaginally, then great, and if not, yeah. That was just and then we moved on. We're past the first. Oh, we've got it again maybe.
Oh, this should say the first month of life, shouldn't it? I think we've got to the end. Yeah.
That's
oh no, we're talking about going to Tetanus. No, we're still on our first week of life. Sorry, I'm getting confused.
No.
So this is a very good topic, I think. Anna, tell us about these foals in this picture. And
well, I just thought when we were talking about first week, it's such a common thing that we all come across to have flexural and angular limb deformities. And I just thought we would just touch mainly on flexural today, but we can definitely chat about other things too. But so yeah, so just because it's such a common thing. So the most common being distal limb contractures, so where there's sort of tiptoes, and these tend to respond really well to some oxytetracycline and potentially some splinting. I quite like using a cast material to make a splint down the plantar or palmar aspect of the limb. Also really like full casts as well for these where they're more if they're quite resistant to being corrected.
And how long are you leaving the cast on for?
Just 24 hours in these real sort of babies. So I tend to yeah, put, if they're quite severe, like so for example this one, I would put it on the first day at the new foal check if it's this severe, and then take it off the following day, and then potentially give up the oxytetracycline the following day, depending on the sort of the response. And by that time we've had a bit of time to sort of monitor that foal and see how it is clinically as well before we give the big dose of oxytetracycline, which we'll talk about a little bit as well. These calf contractures are more sort of tend to respond less well to the oxytetracycline, and also are not quite as simple to splint, so we tend to cast those if they're needed, if needed. And obviously the big I hope this works, I'm not sure it will, but the big reason for the sort of one of the risks if we don't get onto these flexural deformities quickly, these contractures, then they can risk rupturing their extensor tendons quite quickly. Oh yes, it is. Oh, it might work. This is one that hadn't been corrected, and we've got a ruptured extensor tendon here, and you can really see that swelling at the carpus. I don't know if you actually can see that clearly, but hopefully you can see a little bulb.
No, it's a great video.
yeah. But so hopefully by addressing these quickly, we can avoid that. And yeah, so we tend to give 3 grams of Oxytet to a sort of a 50-60 kilo foal, and we do it fairly. I would say I do it fairly happily generally, and without and I do find like very minimal complications with it. I tend to give it through a catheter, so I just use the it just uses a short stay catheter, and to give it a quick scrub, but wouldn't clip or anything, and then just use it as a needle. But if it wiggles around a bit, it's it's not going to come out of the vein. I find that works really well. And I tend to do it, and I don't necessarily run a blood first. There is this case report of renal injury in a neonate that received a high dose of Oxytet, but it does seem to be quite an exception. So we kind of do. I would, if we have to repeat the dose, I do sometimes discuss doing a blood before doing a second Oxytet. But yeah, I don't know what your thoughts are on that.
Well, we talked a bit about this already, and I think it's really tricky because, well, if you check their bloods really early, quite a lot of foals will have an increased creatinine initially. I mean, I think my judgment's probably skewed. A lot of our patients will have a high creatinine when they come in. Do you do it anyway? So you've got a baseline? I don't know, because then if you want to give a second dose, then if at least the creatinine is decreasing. So sorry, often lots of those foals that we would see, the increased creatinine initially is thought to be partly due to placental insufficiency rather than there being anything wrong with the foal's kidneys. So the creatinine itself wouldn't make me panic. But does it make you hesitant about the Oxytet? I don't know, probably not. But yeah, maybe it would help in terms of whether you want to give a second dose. I have to say, I think that paper, it is just one foal, and there's one other paper of one foal. There's not case series after case series of these, and people are using a lot of Oxytet and a lot of foals. So my inclination is that we get away with it. But I guess you would be careful. If the foal was looking a bit peaky, if anyone had any concerns about it other than about its legs, I guess at that point, then you would be being much more careful. Yeah, absolutely. Yeah, this has been otherwise completely normal foals. And I do think, I think the number that we do, as you say, we give it so many foals, and across the country or the world, there'll be so many thousands that receive it and without problem. So I think I probably plan to carry on as is. But yeah, I agree. If there's any question over the systemic health of the foal, then absolutely. And can I ask, do you have many foals where you look at them and then you give them some Oxytet or splint them or both, or the second dose of Oxytet, and then you look and think, oh, we've slightly overcooked this? Oh yeah, so this is why I put this, which is really rare. I'm not actually sure if it was Kelly, so I feel like I just unfairly maligning Kelly. I think she at least took a photo. I'm not sure. But yeah, so it's really so they definitely do become lax. For transiently become lax, particularly on the limbs that aren't affected, because it's so often just one limb. But they very quickly over the next few days will tighten up again. So it's not really worried. This was quite an extreme one. So it became extremely lax, having been extremely contracted. It then became extremely lax, but really don't know why. And but then that is absolutely fine, and it looks quite dramatic and banana-like. But actually, it's amazing how they just strengthen up and tighten up again. So definitely would not put me off. And for these lax foals, how are you managing them? Yeah, I mean, restriction basically is the main thing, and if they're just distal limb laxity with that toe pointing up, we'd just restrict them for the first few days, and a lot of them will really quickly come up and tighten if they're quite sort of resistant or aren't coming up quickly. And then sometimes a heel extension or a caudal extension stick-on glue-on can help, but I don't tend to worry about that for quite a few days, because they do often just sort themselves out. And the only time, especially if they're so lax that they start rubbing and getting sores on their heel bulbs, then I would go quicker to an extension. Cool. Great. Oh, so this is just just a couple of cases on just the kind of thing that we're seeing on the road, and often can sort of can be managed fine. I couldn't go, well, we'll see what this is anyway, but I thought these would be useful because I think I'm aware that probably some of my plans are high maintenance. I think I always come in at the more high maintenance end of the spectrum. So I thought it was useful for Anna to give you the down to earth, this is what we can actually do on the farm attitude.
And which we definitely, I'm sure a lot of you are seeing lots of these as well. So yeah, uneventful birth, stood and nursed fine and passed some fecal balls, and is now just kind of a bit dull and tail flagging, not really unsucked properly. And so often owners, if they're not experienced, will say that they're straining to urinate. But then it's also doing a bit of this colicky type thing. And then on ultrasound, we have these lovely speckled meconium balls. And that's when often people will say, or owners will say, oh, it had an enema, it can't have a meconium impaction. It passed a load of meconium, but actually it's amazing how high. Sometimes you can see the meconium way sort of quite far cranial, and it just hasn't quite made its way out. So kind of back to basics. So often we often see them when they have already had a fleet enema, and because of a phosphate enema, you are limited to how many we can give them. So really, if they've had one, we then move on to different methods or different types of enemas. So so sometimes a soapy enema can work quite well, but it tends to be when we're seeing them on stud, I tend to go for an acetylcysteine retention enema more quickly, because they've often had a degree of or some sort of enema already. So this is where we make a 4% solution of acetylcysteine, and then this foal did positioned itself beautifully. I don't think it needed an enema, but I thought it was just perfect. So yeah, I tend to just elevate the hind end basically, give it some diazepam, and then make a pile of straw, and so its hind ends up, and then infuse normally make it up to 160 ml-ish, and then leave it for about 20 minutes. I often run in a bag of Hartmann's at the same time. It probably just gives me something to do, but also if it has been off-sucked for a little bit because it's been annoyed by its meconium impaction or whatever, then I think it can be useful. And you can get these little kits actually that come with, I think they're called Easy Pass kits, which is the same name as the tolls in the States. Be like the automated tolls on highways. But anyway, and yeah, so that will do everything, but it comes in a kit with all the bits, but you can easily make your own as well. Cool. And then yes, so then I slightly moved on to, I just couldn't not talk about meconium infections, because I feel like it's the most common thing in the world.
And also, I guess the other thing I would say is, I think another reason to just crack on with the acetylcysteine is we would definitely get them in here where there's been a bit of sort of faffing around about the meconium, and it's had various enemas and various people poking around its back end, and then their back end gets really sore. And then it's really hard. Is there meconium left, or is the back end just irritated now? Yeah. So I would be quite pro that just get on and get the stuff out of there. Yeah. And how do you feel about repeated acetylcysteine enemas? Because my impression is they can be quite irritating as well. But yeah, I think they can be quite irritating. I have to admit, it wouldn't be that common that we would see a foal where the meconium really weren't clear. Yeah. I don't know. Yeah. I mean, no, I do. That would be my impression. Yeah. I mean, because you read this stuff, John Madigan talks about the wire whacker thing, where you use a piece of wire to like hook the poop out. I'm so far, thankfully, I've never had to do that. It always sounds a bit dramatic. And I think they can be a bit sort of agitated afterwards, but often it's not necessarily because they're blocked up. It's because they've had it all. And I guess I would be happy at that stage to give them a bit of analgesia. Yeah, true. Yeah. No, I would normally give some as well at the. So this is a bit more of a sort of a flat. So it's not very old, only 3 hours. But hasn't really latched on within the 1, 2, 3 as it should rule, and yeah, maybe a little bit wandery, and then is down quite a bit and not really not really up for nursing. So and if you're sort of called at this stage, so you might see, we've got a good or a decent suckle reflex, and can pretty much stand by itself, just needs a little tiny boost. And I mean, my sort of plan at that stage would be it needs colostrum. I go sort of fairly easy on the volumes. I wouldn't and probably go with even just starting with like 300 mils or something, 200, 300 mils for the first lot. And then it's amazing what just a little bit of colostrum in there can then do if it has a sleep after you've tubed the colostrum. And then it's amazing how they can get up and just be so smart and just go straight to nurse. So that would be at that sort of stage something not quite right. That would be my approach. And it might be that you have to repeat that, but it's definitely worth seeing what they How quickly would you repeat it if it didn't hop up and nurse after a few hours?
I mean, definitely a couple of hours later if you've only given that sort of amount. And often it works because they're often there scanning mares all morning. You often see those foals first, and then can keep an eye over the morning and then go back. And so we're very lucky in that way. But yeah, but even if you were having to visit each time, I wouldn't leave it longer than that, particularly at that stage. And also it should be going in the right direction.
And what I guess I just certainly would agree with you about the volume, but do you have have you had bad experiences if you've tried to give a bigger volume?
Yeah, definitely. If they can so easily become bloated and uncomfortable, especially if they do have slightly sort of it's probably a really annoying word for internal motion, especially the sort of dummy gut or whatever. They and just they definitely can become uncomfortable if we sort of fill them with too much initially. So
yeah, that would be my experience too.
Yeah. Cool. And then a slightly older foal who wasn't seen, the foaling wasn't seen, is pretty dull. Was kind of nuzzling around at the udder a while ago, but didn't really know if it was nursing. Tried to give it some by bottle, and that wasn't very successful. And so this is just slightly quieter foal. Will stand, but does need to be boosted up. And possibly slightly not the nicest, slightly slow capillary refill time, but not sort of cold and horrible, nice warm extremities. So it's not horrendous, but certainly not right. So at this stage again, some colostrum I think is a good idea. Again, would go pretty conservatively on the volumes, but I would definitely that would be high on the list. And then we definitely would go for fluid bolus quickly in the field, and it's amazing again what a litre or two of Hartmann's can do, whether or not it can sometimes do add glucose, but even just if we're tubing as well and the foal's looking, it's looking pretty good, I would just tend to go with plain Hartmann's, and it's amazing how, as I say, how quickly they can perk up. And yeah, I don't know what your thoughts are to fluid to glucose spiking of fluids in those kind of situations.
I guess I do it here, but then I'm always following up with an infusion. I guess my concern in that situation is you just make a big spike, but then it's gone. But you're right, if you're giving them the colostrum, you're giving them additional. I think it's a tricky one. If you can measure their glucose as well, I suppose it's really nice. Do you would you check their glucose at this stage?
So we have would potentially, would take a blood, and we do have just a glucometer back at the practice, but I wouldn't carry it in the car, so it wouldn't be wouldn't help at the time particularly. But I would definitely do a blood, look at the blood work, and then certainly antibiotics would, I mean, that would be one that we wouldn't sit around with particularly.
And what antibiotics would you give it?
Oh, well, yeah, so I would go for ceftiofur probably, and there's the state of the new of the first generation cephalosporin that would be great. And that's becoming more available.
Both are making now.
It
comes in quite big bottles. And why would you choose that over like TMPS or Doxy?
I mean, I suppose just we worry about oral administration of in these foals that aren't sort of 100% in their guts, potentially aren't functioning as well as they could be. But yeah, so
no, I
think it's a thing, isn't it? Yeah,
no, I think it's a sensible decision. I think if their guts are functioning, then I guess you can make different decisions. But until they are, it's much more difficult.
But yeah, I mean, I think the main thing is with these ones that if we're managing them on farm is that they should really improve really, really quickly. And so yes, I'm I would repeat the tubing a couple of times over the day, or sort of at 2-hourly intervals. But you really want to see an upward trajectory, and if it's going the other way, then wouldn't be sitting on it and just keeping on going with that, because it's clearly it may be that foal is more compromised and does need more intensive management. So, and in which case I would pick up the phone. But obviously these are cases, and that's sort of an example if referral is an option. Obviously, if it's not an option, then yeah, absolutely, we would do more in the field. But that's
yeah, and I was only going to talk very briefly. I don't think we need to bore on about hospitalizing foals this evening, but I thought it was useful just to put in these little bits. This is a really nice study. It came from the States a few years ago, but they showed that over the years, this little graph on the left, you have the 1980s on the left, 1990s in the middle, and the 2000s on the right. And those white bars are the survivors versus the non-survivors. And the survival rate of foals being admitted to hospital has increased massively over that time. Some of that maybe is because people have become more proactive about admitting foals to hospital. So some of the ones that come in are healthier to start with, and maybe that helps us out. But I think it's quite encouraging to see that survival rates have improved over time, and we're not just doing the same that we've always been doing. And then these two other papers from the States and from Ireland have shown that actually if foals survive and go home and do well initially, their long-term survival is pretty good. In general, long-term survival is not impacted by being hospitalized as a neonate. The only slight exception to that is probably septic joints, where there is probably a bigger possibility of a long-term impact. It's not a massive risk, but the risk is there. And I just put this in. This probably explains part of why our survival rates have improved. We are able to do quite a lot with these foals now, and the chart on the right is probably universal to quite a lot of hospitals in this country these days, I think. But it just kind of gives you an idea of what we're up to. You know, these foals are having stuff done every hour of the day, and there's a lot of stuff going on, and that's what helps get these good survival rates and outcomes. But also unfortunately does come with a reasonable price tag attached.